So exit site infections are evidenced or are indicated by the presence of drainage and erythema at the exit site. We often try to prevent this with topical gentamicin cream, which is the standard in our dialysis clinics. There is a literature in support of mupirocin cream as well. And even some centers that are using ciprofloxacin, the otic ciprofloxacin at the exit site in order to reduce the chance of exit site infections and peritonitis. Treatment usually involves oral therapy, and we would treat for a minimum of 2 weeks until there's clinical evidence of improvement. We would also increase local measures of cleanliness, including the use of iodine or peroxide, which is used in many cases. Organisms can still include the typical Staph aureus and Pseudomonal infections, and these have a greater chance of progressing to frank peritonitis. And so it's something to take seriously. There is even more aggressive measures at addressing peritonitis. Sometimes the external cuff serves as a fomite or a place where biofilms form and prevent the resolution of the exit site infection. So in those cases, one has to consider exteriorizing that external cuff. That means freeing up the external cuff and allowing it to pull out of the tunnel, and relying on the internal cuff to maintain position of the PD catheter. Obviously, if there's progression to tunnel infection, that catheter needs to be removed, as we discussed. The typical oral regimens that are used, I would say the most common is Keflex. One can, again, obtain a wound site culture in order to tailor antibiotic therapy if you have drainage, keeping in mind that often these external cultures are often polymicrobial and sometimes misleading. You can use, again, Staph aureus coverage with Bactrim. You might also add the ciprofloxacin if you're worried about, again, gram negatives. So those are the typical treatments for external exit site infection that has not progressed to peritonitis. Volume overload as another complication of peritoneal dialysis. We touched upon this topic using the concept of ultrafiltration capacity as a measure of peritoneal ultrafiltration and adequacy. So let's first obviously touch on some of the signs of volume overload. The obvious edema is just that, it's obvious, but the uncontrolled hypertension that previously was controlled is another sign of volume overload that might be a clinical clue. And then some would argue that sort of the dilution of serum albumin that occurs with extracellular volume excess might be another sign, although there's a lot of confounding factors for using albumin as a measure of volume status. Here is a diagnostic algorithm based on whether there is adequate fluid removal through peritoneal dialysis or not. Um, First, of course, in the new patient or the patient who is new to dialysis, one has to make sure that this is not a technique problem, or if there's a change in the support system, you might consider whether technique is the root cause for a patient with volume overload by seeing the patient do an exchange under direct supervision in the dialysis clinic. Um, if you see that technique is not a problem, one can then use the peritoneal equilibration test. Remember that ultrafiltration with that standard 4-hour dwell with a 2.5% dianneal bag, 2 liters, is the definition of ultrafiltration capacity. So if the ultrafiltration capacity is greater than 200, you're leaning against peritoneal membrane failure as an explanation for that volume overload. So you're considering other possibilities like heart failure, um, profound hypoalbuminemia resulting in capillary leak, and low intravascular volume with peripheral edema and third spacing of fluids, or somebody who's just eating a lot of salt and drinking a lot of fluid. That would obviously also be an explanation where a patient has adequate ultrafiltration, but still is coming in volume overloaded. Okay. You also have to consider the residual renal function, even though I haven't put it in this discussion. A patient can be hanging on, let's say, with dietary indiscretion and is maintaining euvolemia in the setting of adequate ultrafiltration and urine output. But when that urine output starts to fail, even though ultrafiltration capacity may not be all that bad, the patient can then manifest volume overload as they lose residual kidney function. All right. When I have ultrafiltration capacity, which is less than 200 milliliters, it suggests that there's a problem with ultrafiltration. Some of that can be from high transport characteristics, as we previously discussed. A reversible explanation for increase in peritoneal transport would be peritonitis, right? We talked about that leaky peritoneum resulting in inadequate ultrafiltration as a sign of peritonitis. And some would espouse if you have a shift towards high transport characteristics, a period of resting the abdomen for several months might restore ultrafiltration or lower uh, uh, rapid or less rapid transport characteristics. Okay. Now, if I don't have a patient who's a high transporter, then I'm looking for other explanations for ultrafiltration failure. So we talked about maybe there's a catheter problem. Okay, so obstruction to flow, either through malpositioning of the catheter or, a problem with a catheter kink, wrapping around omentum, or fibrin in the peritoneal catheter. We can have problems with catheter leaks. Leaks refer to leaks along the subcutaneous tract of the catheter, resulting in a fluid collection that forms under the skin, often around that tunnel, and that results in essentially reabsorption of that leaking fluid back to the patient. And so you have a net ultrafiltration, which is diminished when you have that walled off fluid collection, which is being reabsorbed. Hernias would be a similar walled off fluid collection that ultimately can get reabsorbed by the patient. If you're looking for these leaks, sometimes you have to get your sleeves rolled up and actually inject contrast into the peritoneum and obtain cross-sectional imaging to look for flow of that IP contrast agent. We typically use gastrographin. Typically, nursing doesn't do it. So you have to get the contrast agent from radiology, spike the bag with that contrast agent, and then actually do the manual exchange. I would say roughly once a year. I've had a fellow essentially do this procedure looking for a hernia or a catheter leak by instilling iodinated or instilling gastrographin contrast spiked IP fluid into the patient. And then obtaining CT scan imaging to look for, sometimes this is used also for looking for pleuroperitoneal leaks into the pleural space as a explanation for pleural effusion in a patient on on peritoneal dialysis. That would be another example that I've seen this study done. Uncontrolled hyperglycemia. Remember, the ultrafiltration relies on the concentration gradient between the peritoneal space and the patient's extracellular fluid. And if a patient has chronically uncontrolled blood sugars, then that would reduce the efficiency of ultrafiltration. It reduces the diffusive gradient or the osmotic gradient for water flux. Okay. There can be a drop in peritoneal aquaporins. Remember, these are the ultra small pores in the 3-pore model of peritoneal transport. That too can be addressed sometimes with resting the peritoneum for several months. And then there can be the phenomenon of increased lymphatic drainage, okay, where peritoneal fluid is mobilized back into the lymphatic system and then results in poor ultrafiltration rates. That too might be addressed by resting the peritoneum and may or may not be successful, okay? Questions about the volume overloaded patient. Obviously, this is a common patient that you're going to see on the inpatient side. This is how you would systematically approach those patients. First, again, evaluate for any problems with support systems resulting in technique failures. And then you start to think about loss of residual kidney function. And then finally, how good are they ultrafiltering? And then base your differential diagnosis around that. Okay. When you have a catheter flow problem, that can be the clinical clue for a problem with catheter flows would be that I have long drain times. Okay, so I have long drain times or even installation times. So this should not take, the installation of fluid should not take much more than 15 minutes. And the drain under gravity should be also around 15 minutes or less. Okay, and so if you have that, then again, you might troubleshoot that through the following interventions. Flush the catheter. Okay, that can be done usually with a simple Lurlock syringe, especially on that Baxter transfer set. Remember, this Baxter transfer set can be is compatible. This tip is compatible with a Lurlock syringe. So you'll just take off the mini cap. I'll use this terminology again just to reinforce this apparatus or familiarity with the apparatus. Take off the mini cap, connect to the tip with a Lurlock syringe, twist this in order to open the valve, and then you can power flush essentially this catheter to get out any fibrin clots. Okay. This, on the other hand, is not compatible with a Lurlock syringe. You can still power flush a catheter. This tip right here, this titanium connector, is a Lurlock tip. So you can carefully unscrew this and then power flush this titanium connector as well. As long as the fibrin is not in this limb, you can also essentially free up the any debris that's impeding exchange in the patient. Okay, then assuming that you've addressed the fibrin, you want to prevent further fibrin clots from forming by heparinizing the PD fluid at a concentration of 500 units per liter. Okay, look for the catheter position with a KUB. The tip of the catheter should be down in the pelvis, right? So you recall when looking at a KUB, you can see the pelvic bones, right? And the coccyx. You are seeing this pelvic inlet, this circular area of clear space. You should see that the PD catheter is coiled in this lower abdomen. That's the ideal position for this catheter to be. Now, occasionally, you may get a KUB for some other reason and notice that the catheter is in a different position. So you may notice that the catheter might be in sort of up in the higher, um, it's still in the lower pelvis, but higher up, off to one side. A classic description that your patient may say is that, I have to lay on my right side in order to get my all of my PD fluid out. Okay, that would be a classic history that you might get for a catheter that sits in a position that is outside of the lower pelvis. And then when you see that also on a KUB, you might try those interventions in order to get adequate drainage. When you ask the nurse to drain the patient, tell them to put the patient right side down. So those are examples of what you might see on a KUB, as well as some of the interventions you might use to troubleshoot in the short term. You're also going to use the KUB to look for high stool burden and obviously address that with aggressive laxative use, followed by an in and out exchange. Okay, so you need not do a 4-hour dwell to ensure that the patient's mechanical obstruction is resolved. Just have the patient or have the nurse put in 1 liter in and out and see that it is rapidly going in and rapidly coming out. You can TPA lock catheters that have more, let's say, stubborn fibrin, and then once again, heparinize the exchanges. And then lastly, consider interventional nephrology or interventional radiology consult to reposition malpositioned catheters or to take a fibrin sheath away from the tip of the catheter. I will tell you that often our outcomes with use of interventional radiology to resolve these things is the outcomes are suboptimal. Often you limp along with interventional radiology trying to address it, but ultimately need a surgical repositioning of the catheter and sometimes even excising a portion of the momentum if it's twisting up with the catheter. So that has been my experience. Often we bang our heads against the wall with interventional radiology probably too long before calling it and asking for surgical consultation. All right, so fluid leaks, we already talked about this somewhat. Now, you can have a leak to the external environment where it's not just subcutaneous fluid collection. You'll look at that draining fluid and you can essentially get an Accu-Chek on that draining fluid and confirm that it's much higher than the ECF or the blood glucose, as one might expect with this high glucose concentration of peritoneal fluid. If you have that external leak, you'll rest the abdomen and then gradually advance the peritoneal fluid volumes. So you might start with 1 liter exchanges and then gradually advance if there is no persistence or recurrence of the external leak. We talked about the abdominal wall leaks and the hernias that can result in ultrafiltration failure and how you can find those fluid collections with IP contrast agents. Often when you do have these leaks, they require at least temporarily stopping peritoneal dialysis and getting a PD catheter repositioned or revised by surgery. The hydrothorax we alluded to as well. You can diagnose the hydrothorax or peritoneal leak by measuring a pleural fluid glucose. You'll notice, of course, that it too is much higher than the blood glucose concentration. And then managing these would revolve around stopping peritoneal dialysis and aspirating the pleural space dry, and then resuming PD with lower dialysate volumes. If it still recurs, then one has to obviously consider transitioning to hemodialysis permanently, or even such things as pleurodesis or thoracoscopy, looking for a diaphragmatic tear and performing a diaphragmatic repair. Now, this is a big deal. Many thoracic surgeons are really reluctant to perform pleurodesis. It's a pretty, you know, you can get complications for pleurodesis, um, including a impairment of entrapment, lung entrapment. That's what I'm looking for. So this is really not something that is um, that one would do lightly. And I will tell you again, thoracic surgery will generally be pretty reluctant to do a pleurodesis in a patient. Okay. Moving on to these last few complications of peritoneal dialysis before going over to CRT is the occurrence of pain with inflow or outflow. One can try tidal peritoneal dialysis to address that. We talked about that in previous conversation. And then you can get dialysate that is bicarbonate buffered instead of lactate buffered. Remember, the lactate concentration of peritoneal fluid is 40 millimoles per liter. That is your main base in PD fluid. And some people have invoked this high lactate concentration as being a contributor to the incompatibility of the fluid and potentially causing some of the pain that your patients will experience with PD. And so bicarbonate buffered dialysate would be one possible solution to consider. Blood-stained PD fluid would be addressed by first ruling out infection, and then usually these self-resolve. It's usually a capillary that burst in the peritoneum. It looks quite concerning. Even a few drops of blood in peritoneal fluid look quite concerning. But usually these self-resolve. You might consider actually, yeah, perhaps counterintuitively heparinizing the dialysate. What you're trying to avoid is little clots of blood forming in the peritoneum that result in obstruction of the PD catheter. So that's the reason to consider heparinizing the dialysate in the setting of grossly stained PD fluid or grossly blood-stained PD fluid. Sometimes this can occur with menses as well. So that menstrual fluid can actually flow retrograde through the Salpinges of the uterus and flow into the peritoneum. And so again, that is one potential alternate explanation for this blood-stained PD fluid. Sometimes it can also be from kind of an inadvertent tug on the PD catheter as well, where there's a little bit of a trauma to the tunnel. Okay, so malnutrition is unfortunately a common problem in dialysis, broadly speaking, and then in peritoneal dialysis, it can be especially common. That is because there is a fair amount of protein that is lost in the dialysate. So the average loss of protein in dialysate is around 8 grams per day. So it's like somebody who has severe nephrotic syndrome. Now, just to be clear, you actually have a fair amount of amino acid loss in hemodialysis as well, maybe as much as 5 grams a day. So that too is a net negative nitrogen balance that occurs with dialysis. But one can presume that that net negative nitrogen balance can occur. I guess I can't call it net because this assumes that the patient is malnourished, but that negative nitrogen balance can occur, can be more significant in peritoneal dialysis, okay? Having high transport characteristics or peritonitis would even further accentuate the protein loss in PD fluid. Treatment is ensuring adequate protein intake in dialysis patients, whether PD or HD. The recommended intake of protein is around this, 1.3 grams per kilogram per day, 1.2 to 1.3. So making sure that intake is adequate. You can measure that through measurements of the protein catabolic rate, which you get in your dialysis treatment flow sheets, which we've talked about in our discussions around urea kinetic modeling. You recall that in our discussion of how KT over V is measured in the dialysis units. Remember, this increase in blood urea nitrogen in hemodialysis is a function of my protein intake, or my G is my generation rate of urea, okay, which is based on protein intake over my volume of distribution. So this is one, again, way that you intuit how much protein your patient is taking in. Urea kinetic modeling gives you that protein nitrogen appearance or protein catabolic rate. PNA or PCR, those would be essentially synonyms that allow you to assess your patient's nutritional status. You can do the same by measuring the dialysate urea appearance in the effluent in a patient on peritoneal dialysis, okay? So again, ensure adequate intake, correct acidosis, because we know acidosis upregulates catabolic protein pathways, okay? Consider using the Extranil, okay? Extranil is a PD fluid that's available to you that has amino acids in the dialysate in order to supplement the patient's essentially nitrogen intake. And that would be something one can consider. However, there is no randomized controlled trial data that suggests that patients benefit from such an intervention. Hyperglycemia. The glucose absorption from the dialysate is somewhere on the order of around 75 to 150 grams per day. This would be somewhere around 300 to 600 kilocalories per day, and therefore can worsen diabetes control. So the patient who is a type 1 diabetic in particular needs to modify their insulin regimens if they're on an insulin pump to the dialysis cycles, right? When they're putting themselves on PD at night, they may have to increase their basal insulin infusion rate in order to accommodate the glucose load that occurs through peritoneal dialysis. Generally speaking, the amount of glucose that's absorbed over the course of peritoneal dialysis is probably less than previously assumed. And I think this was recently presented in one of our fellow conferences. Ramesh Saxena has published in this space. Okay. Finally, there's this really morbid outcome or complication called encapsulating peritoneal sclerosis. This is a phenomenon in which you see extensive fibrosis of the peritoneum, not just the peritoneal membrane that lines the abdomen, but the peritoneum that also overlies the bowel, okay? And that can result essentially in obstructions of functional obstructions of the intestines. And this can be quite severe and result in malnutrition and ultimately death. The patients with encapsulating peritoneal sclerosis do have a reasonably high chance of dying of this complication. So it is a really severe outcome that our PD patients can sometimes experience. Okay. This is sometimes manifest by peritoneal transport rates that increase, but with ultrafiltration failure that is expected with those increases in peritoneal transport characteristics. Uh, the diagnosis is difficult. Sometimes you just see nonspecific findings of small bowel obstruction on CT scans. You really, I guess the gold standard would be laparotomy or um, the um, the laparoscopy. Okay, so on laparoscopy, you can also see that there's this encasement with this sort of web-like, it looks like a spider web, web-like attachments from the peritoneum to the bowel wall that are tethering the bowel and resulting in these obstructions. Okay. The risk of encapsulating peritoneal sclerosis increases with duration of PD, as well as bouts of recurrent peritonitis. And there's estimates that the risk of EPS is about 5 or 6% after 10 years of PD. Okay. Um, all right, so often you have to stop PD, and there's a weak data that suggests that tamoxifen may have an antifibrotic effect in EPS.